Hello again, everyone. Welcome to our Telehealth Pulse Check E&M Services webinar. My name is Ashley DeCoto, and I am a specialist with our Provider Outreach and Education team. On the call with me today is my friend and colleague, Leanne Foster, who will be helping out with the chat. This webinar is part 2 of our 2-part series on telehealth. Yesterday, Leanne held the part 1 webinar, which provided a more comprehensive overview of telehealth guidelines. If you were not able to attend that session yesterday, that recording will be available within the next week or so in the training center of our website and also on our YouTube channel. We will also have a recording of this session available in that same training center on our website, and Leanne will be adding a link to the chat for the training center. It will be on our website for about the next 60 to 90 days, barring any technical issues with the recording. And you can access this without having to access YouTube, as we do recognize that not everyone is able to access YouTube from work. However, the recording will also be available on our YouTube channel as long as this information remains relevant and current. Also in our training center, you can find a copy of today's presentation. So if you've not already grabbed that, it is still available for download if you would like to have the presentation to follow along or maybe to take notes, though it's not required. We are taking questions through the chat today, which again, Leanne will be monitoring. I will check in with Leanne at the end of the presentation, time permitting, for any unanswered questions in the chat. We did have a number of questions that were pre-submitted with registration, and I will be answering those throughout the presentation today. All right, for our agenda, we'll start by doing a brief recap from Leanne's Part 1 webinar yesterday. After I do that recap, I will be sharing the top claim denials and rejections for telehealth. Then the remainder of our session will be the interactive Q&A activity. I do want to make note that this session today will focus specifically on non-behavioral health telehealth services. We do, however, have a webinar scheduled specifically on behavioral health telehealth, and I've asked Leanne to place a registration link for that webinar in the chat. This slide contains the acronyms that we'll be using today, and I've gathered these all in one place so that you have this for reference. All right, let's start with a quick recap of Leanne's session from yesterday. Telehealth is a substitute for an in-person visit using interactive audio-video technology. And telehealth visits can be really convenient for both patients and for practitioners. It offers greater access to patient care, which improves patient outcomes, and it could also reduce the patient's out-of-pocket expenses. Telehealth services, like with any service billed to Medicare, must be medically necessary and must be on the CMS list of telehealth services, which we will be taking a look at during our Q&A activity. For services that are provided via telehealth, you'll bill Medicare using the code that you would normally use if that service was done in person, and use either place of service 02 or 10. If the patient is in their home for their telehealth service, you will use place of service 10. If the patient is located anywhere else, you will use place of service 02. So as many of you know, during the COVID-19 public health emergency, or the PHE, there were many flexibilities put in place for telehealth, most of which have been extended. The flexibilities that were recently extended through December 31st, 2027 are listed here on this slide. So first we have geographic restrictions. Prior to these flexibilities, telehealth was allowed only when the patient was located in a rural area and in a facility. With the current extension of telehealth flexibilities, patients are able to receive telehealth from anywhere in the US, including from their home. Now, should these flexibilities expire as scheduled on December 31st, 2027, we would revert back to the geographic restrictions, which again allows telehealth only when the patient is located in a rural area, meaning outside of a metropolitan statistical area, or MSA, or in a health professional shortage area, or HPSA. The next flexibility that's still in place is for audio-only telehealth. So audio-only services are allowed only if the physician has the capability of using audio and video, but the patient either cannot or is unwilling to use video. And then last on our list, we have practitioner type. With the recent extension of the telehealth flexibilities, telehealth services can be provided by all providers eligible to bill Medicare through December of 2027. If the flexibilities are allowed to expire, beginning in January of 2028, physical therapists, occupational therapists, and speech-language pathologists will no longer be eligible to bill Medicare for telehealth services. Also under these flexibilities, RHCs and FQHCs are able to bill non-behavioral telehealth services through December of 2027. Now I want to share our top denials and rejections for telehealth claims. The denials and rejections that I'm about to show you are from data that I pulled for claims submitted to WPS with place of service 02 or 10. So here we have our top telehealth claim denials. First on our list is claims denied while the patient is in a period of managed care. And this would happen when they're enrolled in a Medicare Advantage plan. So make sure to check eligibility. And if the patient has a Medicare Advantage plan, the claim must be billed to that plan. Original or fee-for-service Medicare, meaning WPS, we do not process those claims. Next on our list for denials is not a covered telehealth service. So if you've billed a code with place of service 02 or 10, which indicates that the service was provided via telehealth, but that code is not on the CMS list of telehealth services, your claim would deny this way. Next is duplicate charges, which might happen if payment was already made to you for that service on that date of service. Now, if you believe your claim denied duplicate and error, you may submit an appeal. And duplicate charges continue to be one of our top denials kind of across the board. So you want to make sure that your billing system is not set to auto resubmit your Medicare claims. The next on our list is claim must be sent to the EGHP or Employee Group Health Plan first. So if the patient has an employee group health plan primary to Medicare, you'll submit your claim to that plan before billing Medicare. Lastly, we have not covered when performed by this provider. And this would happen for providers who are not eligible to receive payment from Medicare for that service, such as maybe a chiropractor or a physical therapist in independent practice that's billing for an E&M service. Here we have our top rejections for claims submitted with place of service 02 or 10. For our first rejection, we have missing, incomplete, or invalid place of service. So maybe we have on file that this patient is in an inpatient stay, but you bill with place of service 10 for telehealth and home. So this would be based on our records, meaning if the patient was discharged home, but the facility hasn't updated their billing, you would still see this type of rejection for your place of service. Next, we have rendering physician number invalid or missing. And for these, it may actually say denied on the reason code, but this is actually a rejected claim. Also on your remittance advice, the reason code says to submit a new claim, which is exactly what you would do here. Double check that you've included the physician's NPI and that it's the correct NPI, and then resubmit that claim. Next, we have claim lacks information needed for adjudication. So something is missing from the claim. And you'll look at the other reason codes on your remittance advice, which will give you a little more information. But this could be any of the items required for a claim to process, such as the patient's name and date of birth, for example. So you'll want to double check your claim form and make sure that all of the required elements are included, and then resubmit your claim. The fourth one on our list is incomplete or invalid information for other insurance. If your claim is rejecting this way, you may want to check item 11 on your 1500 claim form, which is a required field. You must include other insurance primary to Medicare in this field. If there is no insurance primary to Medicare, enter the word none. Leaving that blank on a paper claim form will cause your claim to reject this way. Now for your 837P electronic transactions, make sure that you're including the primary insurance policy number. If there's not an insurance primary to Medicare, then you would leave this blank for your electronic claims. For our last rejection, we have missing, incomplete, or invalid provider identifier. And this rejection will occur if you're missing the NPI or have the incorrect NPI in items 32 or 33 on the 1500 paper claim form, or the electronic equivalent loops and segments on your 837P electronic transaction. So this would happen, for example, if maybe you had a typo and keyed a wrong digit, or maybe you entered the NPI for the wrong practice location. I did include this slide here as a reference to help kind of summarize what I just talked about for our telehealth denials and rejections. For your rejections, you'll fix the error and resubmit the claim. Keep in mind that for rejections, the claim was not able to fully process, meaning a claim determination was not yet made, and the claim does not have appeal rights. Those must be corrected and resubmitted. For your denials, your next step will depend on the type of denial you receive, and your remittance advice will really be your best source to determine what's next. It may indicate you need to resubmit your claim, in which case you can correct the error and resubmit. In some cases, though, you may be able to correct a minor error through a clerical error reopening using our SecureNet Access portal. So this might be to correct a keying error for your NPI or to correct your procedure code, for example. And then you may have denials that will require you to appeal if you disagree with the claim determination. And your remittance advice would include the remark code MA01 to indicate that you have appeal rights. And then I did include a link in the last bullet on this slide, which has information on how to appeal a claim. All right, now we're going to shift gears into our interactive Q&A activity. And we've designed this to be kind of a fun way to test your knowledge. So we'll be launching a poll for each question. Even if you aren't 100% sure on the correct answer, we'd love for you to participate and give it your best shot. I'll give you a moment to lock in your answers, and then I'll walk through the correct answer for each question. Leanne will be adding some reference links to the chat, and I will be briefly highlighting some key takeaways from these resources as we go, but I do encourage you to bookmark each of these to review later. And a few of these may be things you saw yesterday in Leanne's session, if you were able to attend that one, but we want to make sure that you have these handy for our activity today. All right, our first question is, which of the following places of service may be used for a service provided via telehealth? You can select all that apply from these options. We have A, place of service 02, B, 10, C, 11, or D, place of service 12. All right, it's so good to see everyone participating. The answer here is A and B, so places of service 02 and 10. This is how you will indicate that the service was performed via telehealth. So if you have a service that's on the list of telehealth services and you've performed it via telehealth, you'll use place of service 10 if the patient is located in their home, or place of service 02 if they're located anywhere else. We had a pre-submitted question which asked, what place of service code should be billed when the therapist is providing telehealth services off-site and the patient is in a therapy clinic? So since the patient is located in a medical facility, which is a location other than their home, you would use place of service 02 for telehealth provided other than in the patient's home. Our next question is, which place of service is used for a telehealth service provided to a patient in a SNF? Is it A, place of service 02, B, 10, C, 31, or D, 32? Give me just another few seconds, still lots of answers coming in. All right, the answer here is A, place of service 02 for telehealth provided other than in a patient's home. And the same thing would apply for assisted living facilities, nursing facilities, etc. Your place of service is 02 for telehealth unless the patient is in their home. One pre-submitted question asked if place of service 02 is only to be reported for telehealth service when the patient is located at a facility. So place of service 02 will be used if the patient is really anywhere except for their home. If they're receiving telehealth services from their home, you'll use place of service 10. If they're in a physician's office, a hospital, a SNF, etc., you'll use place of service 02. Another pre-submitted question asked if a patient is in their dorm room at college and has an E&M service through audio-video telehealth, what is the correct place of service? The patient's dorm room would be considered their home, and you would use place of service 10 in that situation. We had one more pre-submitted question, kind of along these same lines, which asked, when a provider is in one location and the patient is in a clinic office, they are using video, what place of service should be used? And your place of service would be 02 because the patient is located somewhere other than their home. All right. Our next question is, when is modifier 95 applicable for telehealth services? Is it A, always, B, for outpatient therapy services, C, when place of service 02 or 10 are used, or D, never. All right, the answer here is B, only for outpatient therapy services. The place of service 02 or 10 lets Medicare know that this service was provided via telehealth. So other services, like your E&M codes, do not need modifier 95. Outpatient therapy services done via telehealth use modifier 95. So this would be PTs, OTs, or SLPs employed by the hospital. One pre-submitted question asked if modifiers are required if you're using place of service 02 or 10, and the answer to that is no, unless your service is audio only, which we'll get to in a little bit. The place of service 02 or 10, again, this lets Medicare know that this is a telehealth service, so you do not need a modifier to indicate that. Only outpatient therapy services require the use of modifier 95 for Medicare. All right, our next question is, which of the following are true for E&M services provided today via telehealth? And you can select all that apply from these options. Is it A, the service must be medically necessary? B, must be on the list of telehealth services? C, not covered by Medicare? And we have D, patients may be in their home. All right, I think almost everyone got this one right. The answer here is A, B, and D. So first, the telehealth service, like with any service billed to Medicare, must be medically necessary. Next, it must be on the CMS list of telehealth services. If the service you are providing is not on this list, it is not eligible to be provided as a telehealth service. And lastly, the patient may be in their home through December of 2027. We had a pre-submitted question asking for us to cover the online digital E&M codes, which are 99421 through 99423. These are not on the list of telehealth services because they are not considered telehealth. Unlike telehealth, which is a live, real-time audio and video replacement for a standard visit, these online digital E&M codes are for asynchronous care, meaning they reimburse the provider for the time they spend over a 7-day period answering a patient-initiated clinical question through a secure messaging portal. And I have asked Leanne to place a link in the chat for where you can find some more information on these online digital E&M codes. All right, moving on to our next question. For this one, we're asking which of these codes are on the list of telehealth services? And you can select all that apply from these options. Is it A, 99214, B, G0402, C, 99350, and we have D, 99231. And you can use the hyperlink here in this question if you have the presentation downloaded, or the list is also in the first list of the links in the chat for this activity. And I'll give you just a moment for this one since you may have to pull that list up. Give it a few more moments. Looks like we still have some answers coming in. I know this one takes a little more time. All right, so the answer for this one is A, C, and D. Let's take a look at how to find that in case you were not able to pull that list up. I know not everybody was able to get that list pulled up. So I'm going to go out to the CMS website, which is cms.gov. Now, if you did not have that link handy, I'm going to show you how to find it. I'm going to go over to this search bar and I'm going to start typing telehealth, or you'll more than likely see it in the list of popular terms. And usually the first or second result is the CMS list of telehealth services, which I'll go ahead and click on. So from this page, you'll click on the second link, list of telehealth services for calendar year 2026, which will prompt you to download a zip file, excuse me. I have that file downloaded already, but you would just click on that link and it would prompt you to save and download the zip file. Once it's downloaded, you can open that zip file where you'll find the Excel and text files. And you can open whichever format you prefer. They do contain the same information. My preference, though, is to open the Excel file. And I've opened that in preparation for today's event because it can sometimes take a minute or so to load. So here you can do a search for your code. So I'm going to hold down the Control and F key here to do a search. And I'm going to look for our first code, 99214, and I'll press Enter. There we go. You see here that this code is on the list, which means this is an appropriate service to be done via telehealth. Now we can do the same for our other codes. So when I search the next code, G0402, which is the Welcome to Medicare visit, that's not on our list, which tells us that G0402 is not a service that can be done via telehealth. For our last two codes, we'll search real quick for 99350, which is on the list, and 99231, which is also on the list. So be sure that you're checking this list to verify that your service is approved to be done via telehealth. We had a pre-submitted question which asked, what services are permanent versus temporary? So CMS no longer indicates permanent versus temporary on this list. Instead, the codes are listed as maintain or addition. So they do not have a provisional or permanent status like they used to. Rather, they are permanently on this list when the status is maintain, or if I scroll down some or a lot, when the status shows addition, this means that it was recently added. We had another pre-submitted question asking what physical therapy services are billable under telehealth. And I believe there are some physical therapy codes on the list, but you will want to double check to see if the service you're providing is eligible to be performed via telehealth. Keep in mind that there is currently that flexibility in place, allowing physical therapists to bill for telehealth. But should that flexibility expire as scheduled, beginning January of 2028, physical therapists would no longer be eligible to bill Medicare for telehealth. All right, I'm going to head back to the presentation and on to our next question, which is, patients must provide consent to receive care via telehealth. True or false? All right, it looks like 100% of you got that one right. All right, so the answer, as you know, is true. You must get consent from the patient to receive the services via telehealth. And this is something that can be obtained by auxiliary staff, and you'll want to make sure that you have documentation of that consent. And this is different than a consent to receive treatment. This is the patient's acknowledgement and agreement to receiving services through telehealth. All right. Our next question is, which of the following codes may be billed to Medicare? Select all that apply from these options. Is it A, 98,000, B, 98001, C, 98002, or D, none of these? All right. The answer for this one is D, none of these. So it's kind of a tricky question. Medicare does not recognize these audio-only codes. Modifier 93 is used to indicate audio only, except for FQHCs and RHCs, who will use modifier FQ for audio only services. So we were asked if Medicare will pay for these audio only codes. And these codes are listed in the CMS relative value files with a status I, which means that they're not valid for Medicare purposes. You would bill the same code you would as if the service were done in person, and then use modifier 93 to indicate audio only, or modifier FQ for FQHCs and RHCs. We had another pre-submitted question, which asked if you can bill G2211 with modifier 93 or 95. For Medicare, modifier 95, again, is only used for hospital-based outpatient therapy services, which would not apply for G2211. G2211 is an add-on complexity code for your E&M home or outpatient services. If the E&M service was done via audio only and is billed with modifier 93, you could append modifier 93 to the add-on complexity code, G2211, but it's not required since G2211 does not require the use of any modifiers. All right, next. Documentation must include the reason the E&M service was performed via telehealth. True or false? All right, the answer here is false. The telehealth documentation really won't be all that different from an in-person visit. It does need to show that the service was done via telehealth, but we don't need a reason why it was done through telehealth rather than in person. Like with any service, again, the documentation must support that the telehealth service was medically necessary. Our next question is, when is Q3014 billed? And you can select all that apply. Is it A, for the originating site fee, B, for all telehealth E&M visits, C, telehealth visits for patients in a facility, or D, never. All right, the answer for this one is A and C. Q3014 is an originating site fee that may be billed when the patient was located in a facility for the telehealth visit. This would only apply if the patient was physically located in a facility for the visit, not in their home. We had a pre-submitted question which said, dietitian billing, department of the hospital, Q code, or their normal charges with a modifier. So the hospital may bill Q3014 if the patient was located there for the telehealth. The dietitian would bill whatever service they're providing via telehealth with the appropriate place of service based on where the patient is located. A modifier would not be needed unless it was an audio-only service. Our next question is, documentation for audio-only telehealth must show that the physician was capable of audio-video, but the patient was unable or unwilling to use audio-video communication. True or false? All right, you all are super fast on this question. I think that means it's a relatively easy one. Okay, so the answer for this one is true. Patients are able to receive audio-only telehealth services with the flexibilities through December 31st of 2027. The practitioner must have the ability to furnish audio-video telehealth, but the documentation must show that the patient is either unable or unwilling to use audio-video technology. We had a pre-submitted question which asked, when auditing telehealth services, what are you looking for? And this is really going to depend on the service you're providing, but it must meet the requirements for that service, and the documentation would need to show that. The documentation must reflect that the service was done via telehealth and support that it was a medically necessary service. The only other telehealth specific documentation requirement is for those that are audio only. In those audio only situations, make sure the documentation is clear that this was a telehealth visit done via audio only, that the practitioner has the capability for audio video communication, but the patient was unable or unwilling to use the video component. All right, next we have, which of the following are telehealth flexibilities that have been extended? And you can select all that apply from these options. Patients may be in their home. We have B, practitioner type restrictions, C, geographic location restrictions, and D, audio only for non-behavioral health. All right, the answer here is all of these. So let's look a little more at each of these flexibilities. First, patients are able to receive telehealth services from their home for non-behavioral health through December 31st, 2027. Now, if these flexibilities do expire, beginning January 1st, 2028, patients would need to be in a facility to receive telehealth services. Next, for practitioner type restrictions, the flexibilities, again, are allowing for physical therapists, occupational therapists, and speech language pathologists to provide telehealth through December of 2027. This flexibility also allows federally qualified health centers, or FQHCs, and rural health centers, or RHCs, to bill for non-behavioral health services done via telehealth through December of 2027. Next, for geographic location restrictions, the flexibilities allow patients to receive telehealth from anywhere in the United States and territories. Should these flexibilities expire beginning January 1st, 2028, patients would need to be in a medical facility and in a rural area to receive telehealth services. Then lastly here for audio only, we kind of talked about this a little bit with our last question, but the flexibilities allow for audio only through December 31st, 2027. Remember though that the practitioner must be able to use audio video technology, but the patient either is not capable of or does not consent to use of video. Beginning January of 2028, if these flexibilities expire, audio only will only be permitted if the patient is unable or unwilling to use video and is receiving the telehealth service from their home. Also, keep in mind, Medicare does not use those audio only CPT codes that we looked at. You will bill the service using the code that you would bill as if the service were done in person, using the appropriate telehealth place of service, and then modifier 93 to indicate audio only. And then FQHCs and RHCs can bill telehealth. They would use HCPCS code G2025 and modifier FQ if the service was audio only. We had a pre-submitted question asking, for ESRD telehealth, are monthly in-person visits required during the first 3 months and an in-person visit once every quarter thereafter? And based on everything that Leanne and I have seen, the in-person visit monthly for the first 3 months and quarterly thereafter is still a requirement for home dialysis patients. This is not part of the flexibilities under the Consolidated Appropriations Act of 2026, which is what extended all of these flexibilities. Our next question is a scenario. Dr. Fred reassigns to ABC Medical Group with a practice location in Indiana. He provides telehealth services from his home in Illinois for Betty beneficiary who's in her home. Which of the following are true? And you can select all that apply from these options. Is it A, the claim is billed to WPS? B, Dr. Fred must report his home address when enrolling? C, place of service 10 is used? And we have D, Dr. Fred does not need to report his home address. All right, the answer to this one is A, C, and D. So the claim would be billed based on the state of Dr. Fred's practice location in Indiana, which is a WPS Jurisdiction 8 state. So the claim would be billed to WPS. Dr. Fred does not need to report his home address when enrolling. Even though he provided a telehealth service from his home, because he has a physical practice location, he does not need to report his home address. Lastly, and I think most of you got this part right, we know that the claim would be billed with place of service 10 because Betty was in her home. Now, in the case where a physician does not have a physical practice location, meaning they solely provide services from their home, they do have to report that home address, but they are able to suppress that home address so that it does not appear on the care compare list. They're able to do this by marking the address as home office for administrative or telehealth use only on the enrollment application. And CMS addresses this type of situation in the telehealth FAQ, which is in your list of links for this activity. And this type of situation is addressed in question 15. All right, we have just a few more. Next, how would someone request the addition of a code to the list of telehealth services? Is it A, contact WPS customer service? B, ask Leanne and I to add a code? C, email a request to CMS? Or D, email a request to WPS? All right, the answer for this one is C, email a request to CMS. So if you or your provider is wanting to request that a code be added to the list of telehealth services, which we looked at earlier, CMS has information on that page on how to do it. And I'll pull that up real quick to show you what I mean. So I'm back here on the list of telehealth services page where we pulled that list from earlier. And over here in the left-hand navigation panel, you see this request for additions. This page gives instructions on how to request an addition and includes this hyperlink to the CMS telehealth review process mailbox, which should actually open a window with the email address at CMS to send those requests to. Make sure that if you're requesting an addition to the list of telehealth services, that you look at this CMS review criteria over here in the left-hand navigation panel. All right, back to our presentation. For our next question, when are the current telehealth flexibilities scheduled to end? Was it A, 9/30/25, B, 12/31/26, C, all flexibilities are now permanent, or D, 12/31/27? All right, everyone got that answer in super fast. So the answer is D, December 31st, 2027. We saw a lot of comments within the pre-submitted questions asking for these flexibilities to be made permanent. We saw the comment, when will the uncertainty end? And probably my favorite comment was a fun play on the webinar title, which said, We are all in need of a pulse check with the telehealth extensions, and just know that we get it. We know it's tough. We want to make sure that we provide you with all the resources and share communications from CMS when anything changes as we move forward with these telehealth flexibilities. We were also asked if the government will ever create or implement permanent telehealth legislation, removing geographic and originating site restrictions. And this is not something we can answer. We have to follow CMS guidance. WPS is not able to impact or create these laws, but we will continue to communicate what we know. I want to pull up one last resource, which is the HHS telehealth page, and it's the last link in the chat for this activity. So this is probably my favorite resource out there for telehealth. There's so much information on this website, way more than we have time to look at today. But what I want to show you specifically applies to the flexibilities. So I'm going to click on the second drop down, which is for providers, and then I'm going to click on billing for telehealth. From here, there are several links you may find helpful. There's this billing and coding Medicare fee-for-service claims, which has some information on modifiers and place of service. There's also this link for billing Medicare as a safety net provider, which provides information for RHCs and FQHCs on telehealth billing. We did have a pre-submitted question asking what revenue code should be used for telehealth in an RHC. So RHCs and FQHCs may bill for non-behavioral health services furnished through telehealth, again using HCPCS code G2025 with revenue code 052X. And this information is available on this page here for billing Medicare as a safety net provider. But the part of this website that I really want to show you is in this top link, Medicare payment policies. So once you click on that, this page is divided up into two sections. Up top, you have all of the flexibilities under telehealth policy updates. Then if I scroll down, the bottom part of this page is dedicated to permanent telehealth policy. So this is really a great place to go if you're confused by what is permanent, what is a flexibility, and when the flexibilities expire. And they've done a really great job of updating this site pretty quickly as the flexibilities have been extended. All right, let's head back to our presentation, and we have one more quick question left in our activity. All right. Our last question is, how are flexibilities applied for telehealth services between 1/31/26 and 2/4/26? Is it A, as if there was no lapse, B, flexibilities do not apply for services during that time, or C, telehealth was not covered that week? Or you can choose D if you just don't know. All right, I see some of you do know, some of you don't know, and that is perfectly okay. The answer is A, as if there was no lapse. Previously, before the last extension, the flexibilities were set to expire January 31st. The Consolidated Appropriations Act of 2026 was signed on February 3rd, and then CMS subsequently updated their telehealth FAQ with the extension of the flexibilities on February 4th. The flexibilities do apply retroactively for those dates as if the flexibilities never expired. All right, here we just have a few additional resources. We have the E&M Services Guide, which has a section on telehealth. The Claims Processing Manual, Chapter 12. This is where you'll find information on permanent telehealth rules. It does not reflect the flexibilities. Then the next one we have is an MLN on telehealth and remote patient monitoring. And then lastly is the CMS Telehealth FAQ. This is the most up-to-date resource on the CMS website, and they actually just recently made some more updates on the 17th, I believe it was. So it does reflect the recent extension on the telehealth flexibilities. I really encourage you to take a look at that FAQ if you've not seen it yet. All right, I do have one more pre-submitted question I'd like to address here, which is what time threshold must be met for G0508 and G0509 because this description says typically X amount of minutes. So these codes are critical care telehealth consult codes, and they do not have a hard minimum time. Rather, the description indicates an average time, which is typically 60 minutes or typically 50 minutes. Keep in mind, though, for these codes, that by definition of critical care, if you spend less than 30 minutes, you have not provided critical care. All right. Out of respect for everyone's time, we will not get to chat questions today, but please don't worry. I will send out an email to everyone who attended today with answers to any unanswered chat questions. If you do think of any additional questions, you have 7 days from today to send those to Leanne and I. And you'll send those to our education mailbox and make sure to include the title of the webinar, Telehealth Pulse Check, E&M Services. You'll want to put that in the subject line so that they make sure those emails come to us. Please keep in mind that we're not able to access any claims history, so you will want to contact customer service for any claims related questions. In a few minutes, you will receive an email to thank you for attending, and you don't want to delete this one without reading it. This email contains your certificate of achievement. It will have your name and contact hours if you need to turn that in for credit towards continuing education units. If you did not receive the email, a few things may have happened. First, you may want to check your spam or junk folder. Also, be sure to add messenger@webex.com to your safe sender list so that any future messages would show up in your inbox. Also, if you joined by phone only, you would not have received this email as there's not a way for us to capture your email systematically from the attendance record. No need to worry though. If you joined by phone, you are able to email us with the phone number you joined with to request your certificate of attendance. And Leanne will be adding that email address to the chat. All right, lastly, please take a few minutes to complete the survey. You can tell us what you liked, what we can do better, and you can also give us ideas for topics for future education. You'll have a few different options to take the survey. You can use the link that Leanne will be placing in the chat, or when you exit today, you'll be prompted to go to an external site, and that external site is the CMS Qualtrics page. And the prompt will look like this picture we have shown with the little yellow triangle. We included this image so that you know this is safe. It's not malware or anything like that. If you're one who's listening to this presentation through YouTube, you also have the same opportunity to provide feedback. You will have a survey card at the end of the presentation. All right, that concludes our webinar for today. On behalf of myself, Leanne, and all of Provider Outreach, we thank you so much for taking the time to join us and participating in the Q&A activity. We look forward to your survey feedback, and we hope to see you again at future events. Everyone stay warm out there and have a wonderful afternoon. You may now disconnect.